And of course, thank you for this invitation. I'm very proud to be part of the EWNC Academy, and congratulations to Hassan for his effort for each time with this beautiful meeting. Okay, my talk could be connected and linked with the previous talk about complications following endoscopic surgery, especially following pituitary surgery. This is a case report and a review literature. Delayed vasospasm following pituitary surgery is a rare occurrence and mainly is reported after transsphenoidal surgery for pituitary tumor, but it has been observed, this delayed vasospasm, also after transsphenoidal surgery for craniopharyngioma, and also after craniotomy, even for pituitary tumors, even for craniopharyngioma. But as you see, the mainly is after pituitary tumors. So our case report is a female patient, 73 years old. A clinical presentation is blurred vision, ADH, dizziness, loss of recent memory, diplopia, and altered mental state, and with impaired endocrinological status. The preoperative MRI showed this large cellular mass with a compression of optic chiasm, optic nerves, A1, ICA. So she underwent surgery, and with a transsphenoidal route, there was a resection of the mass, and the surgery was an uneventful mass without any kind of complication, in particular no bleeding and no CSF leakage. And as usual in our department, basal reconstruction has been done with autologous abdominal fascia. This is the postoperative D2 CT scan, and we can say the blood in the surgical field, subarachnoid hemorrhages. With a mild hydrocephalus, you can note the minimal enlargement of the temporal horn without any signs and symptoms. So it's I think a classical CT scan, no worry CT scan. But 10 days after surgery, the patient suddenly developed aphasia and right hemiplegia with preservation of the conscience. And of course, we performed CT scan, angio-CT scan, and cerebral panangiography, and we will see the radiological course. After that, as you know, the CT scan showed a blood resorption on the surgical field, but we know that the ischemic areas in the yellow circle. So for this reason, we perform a perfusion test, perfusion CT scan, and the perfusion CT scan showed some ischemic progression of the patient. And so the angio-CT scan performed showed vasospasm in left A1, left M1, and M2, and also partial vasospasm in the right A1. So we performed angiography that disclosed a severe vasospasm of left MCA and ACA, and for this reason we perform a selective microcatheterization of the left A1 ACA to see a better way this vasospasm. And the neuroradiologist performed the treatment with intravascular nimodipine, and you can see how after the infusion of 5 milligrams of nimodipine, we can assist a bettering of the vasospasm. So this is the control after 3 days, and we can see the A1-M1 stability of the vessels diameters, but in M2 we can assist a little bit worsening of the situation. So we decided to perform an additional endovascular subministration of 3 milligrams of nimodipine with a bettering of the vascular diameters. The CT scan after 4 days of the last endovascular treatment showed the ischemic lesion in the left ACA and left MCA areas, mild blood infarct in left parietal parasagittal area, and a small amount of blood in the lateral ventricles, especially in the occipital horns, with still subarachnoid hemorrhages in the interpeduncular cisterns. After 1 month, the angiography performed showed good results of the vasospasm, and the patient was discharged in for the rehabilitation facilities. This is the last CT scan after 7 months from the surgery, and with evolution of the known ischemic areas, and left and a mild extracorporeal hydrocephalus without any symptoms about this. And the last clinical feature is right hemiplegia, aphasia. The language comprehension is preserved, simple order execution, no cranial nerve deficit. So this complication is a rare occurrence, and we study, of course, a review literature about this. There is a 30 publication, 3 review, and 27 case reports. About the number of cases, 29 is pituitary tumors and 30 craniopharyngioma, and 6 others like rectal cleft and so on. The main patient underwent transfemoral surgery, especially for pituitary tumors. Also, some patients underwent craniotomy. So the delayed vasospasm is reported mainly from transfemoral surgery, but also a few cases after craniotomy. The percentage of post-operative subarachnoid hemorrhages, like our cases, is the main CT scan features reported, and there is this is true even for transfemoral surgery, even for craniotomy. And the average delay of vasospasm usually after 1 week, no before than 1 week, the delayed vasospasm can occur. So about the data of literature, the subarachnoid hemorrhages at the CT scan is the much more predictive factor to be aware about this occurrence. Other events are reported in the literature like intraoperative CSF leak, hyponatremia, diabetes insipidus, but without the value of predictive factors like the subarachnoid hemorrhages. And we can see here in this graph how the relationship between the presence of subarachnoid hemorrhages and delayed vasospasms is very clear, especially for pituitary tumors, because at much more frequent pathologies and surgery. So conclusion is that we should have a standardized protocol, and maybe to perform a CT scan after pituitary surgery could be a useful point of view to predict this kind of occurrence. And for sure, maybe to evaluate the indication to deliver a nimodipine as a preventive for vasospasm. Thank you for your attention.
Thanks a lot, Dodo, for excellent presentation. Is there any question from panelists?
Okay.
Okay, thank you.
Thanks, Corrado.
Thanks, John.